Good morning. I'll just say a couple of words and then we're gonna start a few presentations that we have. So first, thank you everyone for such a short notice, making this Saturday for all of us. This has been my dream to have this day because I hear for so many families how they don't get to meet other families, and we all know that there are families in the area. So kind of getting everyone together is so critically important. And then also for us in the kind of in the healthcare to hear from you, and obviously this collaboration of families, science, health is how we make progress. So it's been a dream of mine to have this day, and I only apologize that we had such a short time frame between getting confirmation from the Friday Center and getting the day going. So sending the invitation, which has been admittedly way too short. So I hope that for our second day, well, for sure we'll have a longer notice, and I hope that we can have more families and others that could participate. So I want to really thank everyone that worked to get this together. And we'll start. So first, just to say, there are restrooms here. Out the door there is where the kids are, which now I realize that some of the parents are not here. Yeah, James' parents, I realize, are not here. Yeah. So they're right there, and can call parents if something is needed. What else? There's a room in the front if someone needs kind of a quiet room. There's a room at the very front next to the check-in desk. That's about it. Yeah, and our first presentation is going to be Ayat, our social worker. So when she gets back, we'll start. Oh, hey. Oh, actually, I was thinking, just as preparing, this just came to me, meeting some of you. So maybe we'll go first around the room for people to introduce themselves and what's kind of their connection with this day, if people are would like to start. Okay, who's gonna start? All right. Kimberly, do you want to? Also work with all of these amazing Hi, I'm Rachel. I'm a nurse practitioner at Duke, and I work with the Therapeutics.
Hi everyone, I'm Dr. Cushing. I'm one of the new pediatric colleagues of the treatment and integration.
I'm David Kahn, father to Amelia and Mackenzie, single 3 with 15-year-old girls in the living chapter. That's it.
Hello, everyone. My name is Hope Gazelle, and my daughter, Sybil Gazelle, is 24, and she has CLN7, and we live in Columbia, South Carolina.
I'm Ohnsman. Live in Iowa. I have a son, 9-year-old, Ashan. Yes, yeah.
Object.
All right, I'm Eric Stanley, and my wife Kelly Stanley. We have a son named Yael. Has CON3. We've been, at Duke for about 11 years now. Going through various treatments, and, we have a few different doctors here that have been with us along the journey. But, yeah, that's us.
I'm Margot Silverstein, pediatric ophthalmologist at UNC. These injections, Renaissance and underrepresentation. We have our students.
Alexander Graham, career IOD specialist. Now I spend unlimited time doing my job myself for the rest of the not even
Right.
My name is Ayat, and I'm one of the social workers at UNC Neurology. I'm super happy that we're all here together today.
All right. So our first presentation, Ayat and Karen. Okay. Right. Yeah, you're good. Perfect. All right. So Karen and I wanted to get together and present on some common resources that impact families or that can be useful for families with children with Batten disease. So today's agenda, we're going to be talking about IEP and 504 in school. We're going to talk about Medicaid transportation, Make-A-Wish, and North Carolina HIP program. And then Karen's going to touch on palliative care and complex care and therapy for parents. So as a show of hands, do anyone's kids have IEP or 504 in school already? Okay, great. So it looks like everyone's already pretty familiar, but these plans provide accommodations for children in school as they need them. And IEP and 504 are pretty different, but they do share some similarities that are outlined in this Venn diagram. I do have some resources over here on the front that I'm going to pass out at the end of the presentation for people to go over. But if you are interested in an IEP or 504 plan and you don't already have one of those in school, there is a template for an email that you can send the school along with, if you get a letter from your provider in support of an IEP or 504 plan. Medicaid transportation is another resource that some families might not be aware of that they're eligible for if they have Medicaid. So Medicaid transportation provides transport to and from appointments, but it also provides gas reimbursement. So this is especially helpful for our families that are traveling long distances to their appointments. If your child has Medicaid Direct, then you would just reach out to your local DSS office to initiate that process. If your child has managed Medicaid or a tailored Medicaid plan, then you would just look at the resource packet and it'll give you the number of who you'd reach out to get that information. But either way, you're eligible for the transportation itself or gas reimbursement. All right, Make-A-Wish. I don't know if
your families have already gone through this process or if you're interested, but Make-A-Wish assists children who are diagnosed with critical illnesses. Batten disease is a qualifying neurological condition for Make-A-Wish. So if your child is over 2.5 and under 18, then they're eligible for a wish. If you're interested in a referral, you can reach out to your clinic social worker to discuss, or you can actually self-refer. And the Make-A-Wish website will be included in the references packet. Has anybody done a Make-A-Wish already? Awesome. Awesome. Does anybody want to share what they did for their wish? Yeah. Oh, wow. Oh, that's super cool. Great. Yeah, I know they do a great job. They're a well-oiled machine for sure. Yes. Oh, yeah. Wow.
Big truck manufacturer, and then they said that home, or after we got home, they ate and over 280. Then we would give it to,
I was about to say, this is me, big one. My email, he wrote a train. The city of Denton brought out a garbage truck, which was private property, just told him to go have fun. He also got the bright orange 18-wheeler fresh off the line and into the back chest parking lot. And the big figure. Yeah. That is
Oh,
It's our,
yeah.
our son, they came to ask him what he wanted, and they offered him a little bit of, like, or the big trip to Disney World. But he told them no, he wanted a playing machine or a claw machine.
Yeah.
A full size. So, he told us this was early on, and, so they went through all the different things that they could do and where they could go, and he said, no, I want the claw machine.
Yep.
So anyway, David Buster's provided a full-size claw
Wow.
machine that we still have in our front door before you of our house. And I don't know anybody else that has one. That's where it's at. And he has enjoyed it over and over and over. So it's an experience that he was right, I guess is what I'm trying to say. You know, sometimes we have to listen to the kids.
Yeah.
So he was right about what he wanted. And so when going back and forth to Duke, and even when he was sick, he would come home and he wanted to play the claw machine.
Oh.
To this day, he still wants to get in front of it and play. I think he said it this week today. So
They final thing for he and all his friends, family to go to Dave and Buster's.
Oh.
Party, and then presented the claw machine and also
I think TV come out, that's the article.
and then also a toy shopping spree.
Oh.
They went all out.
Yeah.
That's what's here.
Yeah.
Toys R Us shopping spree for he and his.
That's so sweet.
Yeah, the claw machine.
Yes.
But yeah.
Sounds like a staple in the household.
You have to walk around it every time. Oh, no. But it's fine. No, but we have to explain it every time someone, there's a reason for this thing. But no, it's been fun.
Great.
But anyway, this one's.
Yeah, no, that's awesome. Well, thank you all so much for sharing that. That's so special. And I hope that if you haven't had a Make-A-Wish, that you have the opportunity to do so. The next program that I wanted to discuss was the NC Health Insurance Premium Payment Program, which is called NC HIP. So if you have Medicaid and an insurance through your employer, this program pays to make sure that, you and your families receive health insurance, and it can actually pay your premiums. So it's completely free for those who apply. You keep your Medicaid coverage and also receive the benefits of your other insurance. The website, again, is going to be on the reference guide. So if you haven't already applied for this program and want to take advantage, you can definitely apply. Great, I'm going to pass it over to Karen now. Thank you all so much.
Yeah, okay, cool. Hi, as I said, I'm Karen Kahn, a mom to Amelia and Mackenzie, who are 15 years old now. And what I want to talk about, I guess we all remember Diagnosis Day. So on the left there is the girls. They were 7. Actually, it was right before their 7th birthday. I think all of us, Diagnosis Day is stuck in our brain forever. And their Diagnosis Day just happened at that point. Amelia had been diagnosed with autism. And then obviously, at that point we thought just vision loss. So my sister was coming out to visit just to be with us, because at that point we thought we had an autistic, blind child, and we're like, okay, we can tackle this. And she just happened to be in town when we got the call that genetics were back. And so we went to the geneticist, found out, and also on that day, it just happened that it was our crazy miniature poodle's 15th birthday, and we knew she wasn't going to make it. So like literally probably 6 hours after getting the diagnosis, we were having a birthday party for our dog. But the most amazing thing that happened, I guess I can say amazing now, but with my sister being there, she's in the medical field. And in that first week, when she was essentially taking care of my sister and I, she did 2 things for Dave and I. And that was, she found us a grief counselor. And then she also contacted palliative care. And I think like everyone else, when you hear palliative care, I had to Google what it was. I'd never heard of it. And I was horrified that she had actually suggested that we go see palliative care. I was just crying at the thought that we had to do that. Our girls were 7 years old, seemingly healthy, minus vision. And the thought of going to palliative care was just horrific. But we started early and we learned. I just wanted to really say how important it's been for our family and how critical for our family it was to start when they were 7 years old. And in the beginning, we just went and talked and we met the doctors, and, they got to know our girls and how silly and funny they were, at that point. And so we probably went every 6 months in the beginning. And by the time we moved from Arizona, we actually were talking with our palliative care doctor once a month, and just kind of catching up on things. And it's just palliative care is, for us, it's quality of life. It's not end of life, it's quality of life. And it really allowed us to kind of have some of those, build a rapport with the doctor and have some of those conversations early and slowly. So that, when 3 years ago, when Amelia ended up in the PICU from, RSV, she got RSV, seemingly, healthy 12-year-old at that point with Batten disease, but within a matter of hours, she was on a ventilator. And, we had that connection with our doctor that we weren't having those hard conversations for the first time. And really, they became our quarterback here at UNC. It's, we have palliative care, but really it's become complex care. And there's kind of 2 things here since we moved to North Carolina. We have complex care, and they are the quarterback of all of our doctors. We have an ongoing every 2-week call with them, and they're the ones reaching out and following up with other doctors so that we don't have to. And they're talking behind the scenes and making sure everything is, we're optimizing the quality of life for the girls. And the other thing, I guess, here in North Carolina is there's something called transition kids, because, and they really are palliative care that transitions into hospice. And I didn't understand when we moved here the benefit of really engaging with transition kids, because we had, complex care at UNC. But it's the same thing that it was in Arizona. And, we have every few months, we have a conversation, we just have a virtual appointment with transition kids. And it's the same thing of another eye on the girls, just kind of coming up with, different suggestions. But then also they are getting to know our family and the girls. So when the time comes to have that conversation and switch the girls to hospice, and you can go back and forth between hospice and they can get better and go back to palliative care. But having that conversation now and them knowing our family and really bringing up those hard topics with us has been really valuable for us. And I just think coming from another parent, because I know sometimes a doctor suggests palliative care to you and it's just, like me, at least it was my sister who told me, so I could just, get mad at her and forgive her. But it's been incredible for us to do that. So sorry. And I didn't switch it because I'm not good at this. So anyway, that was what I was talking about. So the other thing my sister did then was that she found our grief counselor. And within the first week of diagnosis, there are only 2 girls. So really for us, it's what does our life look like now? It doesn't matter if you have 1 child, 2, anyway, Batten disease, your life is forever different. You view the world differently. And so that first week we were at grief counseling and it was critical for Dave and I. I think we went twice a week in the beginning. And then it became the once a week, and it was afterwards it was our date night or our date lunch, because often it was kind of during the day or whenever we could figure out to make it happen. But it allowed Dave and I to talk about it in a safe space and really appreciate the fact that we were dealing with it differently. And a lot of it also was, it's not just us, Dave and I dealing with the diagnosis of the girls. It's everyone in the family. I'm sure you all know everyone in the family is affected. If you have other children, their relation, just their world. And for us, it was our relationship with our own parents. The grandparents are grieving for their own children and their grandchildren, the relationship with our siblings, just even dealing with just seeing typical children now, our nieces and nephews who are typically developing and everything all of a sudden, you can't understand why people get upset over little things, you just have this new perspective on life. And so it was a lot of talk about actually our extended family in those early days and how they were processing it and how it was stressful on us. And we don't have any typical children, but I know I've heard from other families the benefit of having those other children also, go into therapy and have a safe space to talk about it. And the one thing I just gonna end with, but our, counselor said to us we had the most amazing counselor in Arizona. At the end of every single time we went there, she just said, looked at Dave and I and just said, be kind to each other. And I really took that to heart of just, when one of us is struggling or we do something stupid, it's just understand that they're just trying to deal with this as well. So just be kind to each other. So.
All right. Thank you guys so much for talking about that. I think that is so important, and I think it comes a lot to hear it from another family. And so thank you for sharing that. And so just to introduce myself, I'm Shital Patel. I'm one of the pediatric neurologists over at Duke, and have the, like I said, privilege and honor of taking care of patients that have Batten's disease. And so today, my talk is really just going to be a bit more about like the science and how based on the science, there's hope when we understand the mechanism of action of how these diseases come to be, and talking about different therapies that are down the pipeline as well. After me, both Dr. Shiloh and Dr. Ohnsman from Tern Therapeutics are going to go into more detail about some of the very unique and exciting therapies that we have. So I know we already know this, but just kind of for some reference and some review, kind of what is Batten's disease. It is a group of diseases that we call neuronal spheroid lipofuscinosis, and can be caused by a change in over 13 different CLN genes. And there's different forms of Batten's disease, as we can see here. And a lot of our families have talked about having CLN2, CLN3, or CLN7. There's up to 13 or more. Estimated about to be 2 to 4 births per 100,000 in the US. I feel like I don't need to go over this because I think we've already kind of seen this and progressed through this. It is rare, but it is, I think, what we see, what we live with when we take care of them and when you guys go through your everyday today life. And so I really wanted to show some pictures of you guys because that's what it is, right? It's the families that we take care of and the kids that we take care of. But over time, we start to see seizures, different motor decline, vision loss, and other changes as well. But why does that happen, right? So what causes Batten's disease? So for this, we have to take a trip back to our science class in like 7th grade or 8th grade biology when you had to make a little cell and you had to draw out all the different things in the cell. And so we're going to talk about a specific part of the cell called the lysosome. And so what happens is the lysosome is kind of our cell's recycling center, right? So it helps us get rid of bad stuff that we don't want around. And what happens in Batten's disease is in some of these different CLN genes, there's different or missing or broken parts of this machinery. So our cells can't get rid of that stuff that we want to get rid of over time. And so that leads to kind of this accumulation of waste, oxidative stress, and kind of leads to some of these neurons dying as well. And so that's kind of the basis on the disease process in which Batten's presents itself. And then so I'm going to talk a little bit because I think sometimes it gets confusing because there are so many different forms of Batten's disease, right? We talk about CLN2, CLN3, CLN7, CLN1, right? So many different forms, but why are there different forms, right? Is this just one type of gene that we're impacting? No, it's actually many different parts. And so I don't know if you can see my diagram here. But I think that this is a really helpful diagram. And so I'm going to walk you through the diagram first. And so this is our cell. And as you can see, this is our cell membrane. This is our nucleus. And then you can see that these little blue things over here are our lysosomes. And this is just a schematic, okay? And in there, we can see that there's different types of CLN genes. And so when we think about the different genes, they all have different purposes. So just to kind of show you guys on here, we think about CLN2. So in CLN2, there's an enzyme in the lysosome that kind of helps break down proteins, TTP1. And so when we have a deficiency of that enzyme, so we have a lack of that enzyme, what happens is that we end up having a buildup of those undigested things, and they kind of end up kind of puffing out that lysosome, puffing out that cell with that accumulation over time. So that's CLN2. But so when we take a look at CLN3, that's a little bit different. So that, yes, that ends up being what we call, so this is our lysosome over here. So this time it's not inside the lysosome doing things, but it's actually on the membrane or on the outer part of this lysosome. So it's this transmembrane protein that has a defect in it. And then specifically with CLN7, similar in that this is kind of the way that it impacts as well. And so different genes in CLN, right? CLN2, CLN3, CLN7, but all of them somehow impact the functioning of the lysosome. And that's what we kind of take away from. And then over time, when we have this dysfunction in this lysosome, that's what overall leads to kind of neurodegeneration of these cells with time. And so today, what I'm going to do is we gave a little bit of background about, the cell and the lysosome and why it's so important and how these different CLN genes play a role. But I'm going to now talk about what does that mean? What does it mean that we see clinically? What does that mean treatment-wise and options as well? So I'll go through each. I'm going to go through CLN2, CLN3, and CLN7 now. Thinking about CLN2, so we'll just go in numerical order. So in CLN2, we have a deficiency of TPP1, and that ends up having impaired protein degradation. And then I like this schematic here, because what you guys can see here is that this is a healthy cell over here. And in this lysosome, you have this enzyme, and this enzyme helps kind of break up this storage material. But what happens when you have a cell that has a deficiency of that is that can't break it up. And so you see a lot, instead of having just a small amount of these triangles that then get broken up into these small pieces, you end up seeing just build and build of these as well. And that's the main functioning of how that happens in CLN2. So what does that mean for treatments? And so for CLN2, we do have an FDA approved treatment, which is Brineura. And Brineura is enzyme replacement therapy. And that is because what is deficient in CLN2 is an enzyme. And so we're able to replace the enzyme. And then in 2024, it expanded to being able to treat even pre-symptomatic children as well, which we're able to do. And it does show slowed motor and language decline, and the best outcomes are seen with early initiation. With everything, there's benefits, and everything, there are side effects, right? So to be able to do enzyme replacement therapy, I feel like I should have the families up here to talk about their experiences having to come in every 2 weeks to have an infusion done. It's not a simple thing, right? You have to drive, you have to come. We may or may not use sedation to be able to do the infusion process or to do the hookup, spending like the 5 hours there with your child and then going home every time. And then each time, so happy when we don't have an infection or anything else like that, right? Like that happens, but there's a worry, right? Because we're doing constant of that. So invasive, costly, not curative, but so much improvement. We have a family that we were able to start at around like 8 months of age with Brineura infusions, and almost 2 now with completely still normal functioning. And I'm sure that family would want me to mention that. And they're unable to be here though today. And so great treatments, but right, is there something more that we can do, right? So we have a great FDA approved treatment now, but what is kind of coming down the market? And so this is what Dr. Ortson will talk about in a little bit, but we are looking in Tern Therapeutics. There is going to be a CNS gene therapy and a retinal gene therapy. And I you'll probably go into more details, so I won't spend a lot of time kind of reviewing this, but the idea is that through this type of gene therapy, we could overall get that cell machinery to start producing good TPP1 enzyme. And if we can do that, then can we be able to degrade all that extra material lipofuscin that we don't want to be there and not have a buildup? And can we see either reversal would be amazing, but even stabilization of the disease process. So that's what we're hearing about soon as well. And so moving on to CLN3. So in CLN3, what we talk about when you kind of take a look at a healthy lysosome and an unhealthy lysosome. So now this is just looking at the lysosome, that small part in the cell as well. And so this is one of those kind of transmembrane proteins, and we have a deficiency in that, or a defective one there. And therefore, over time, you also can get a buildup of material in the cell. And so this presents a bit differently. And so in CLN2, oftentimes when we first present, we might see some delays early in life, and then seizures, which then lead to genetic testing, and then we get our diagnosis. In CLN3, oftentimes one of the first things we actually see is vision loss. So our families will often present to the optometrist or ophthalmologist, get some genetic testing done there, and then kind of come being referred to us because that's initially the first symptom that it presents with. And then specifically for treatments for CLN3, we're going to talk about a few things. I'm going to talk about a treatment that isn't a specific gene therapy, not one of kind of these enzyme replacement, right? Because it's not an enzyme that's missing in CLN3, right? So not one of those types of therapies, but a therapy called miglustat, which is actually a substrate reduction therapy. And the idea is that there's that buildup of that bad material. And if we can get rid of that bad material, can there be stabilization? Can there be some improvement in CLN3? And there is some early data to show some stabilization as well. Still not FDA approved, but something that's better than nothing, right? And we're trying to find something that can be helpful, right? And that's what our goal is. But in addition to this treatment, there's different types of gene therapy coming down the line. I think when we think about gene therapy, we're like, well, is it just one shot and one thing that can improve it, like an AAV vector-based therapy that delivers the material to make a good protein in this case, or are there other ways that we can approach this as well? And so this is what Dr. Shiloh will talk about a little bit of N of 1 or N of 2 therapies, about personalized gene therapies for specific CLN3 genetic mutations. So it's not for all CLN3, but specific types or common mutations. Can we create something that will help us kind of rescue in that way? And so we'll hear a little bit more about that in a little bit as well. And so to move on to CLN7. So in CLN7, this is also a lysosomal membrane transporter. It's actually the MFSD8 gene. And so pretty kind of similar kind of concept of what ends up happening in the lysosome as well. And there are also some unique treatments kind of down the line for CLN7. So also this concept of personalized ASO, which is a type of gene therapy, also AAV-mediated gene therapy as well. They've also tried to use miglustat or a substrate reduction too. And I want to spend a little time, I know we have a few more talks. I don't want to take up too much time, but I want to talk about why I think understanding the mechanism of how these diseases is really important. Because I think once we can understand that, we can then create a rational therapy design or plan. And so just I think the idea in CLN2, being able to personalize, hey, we're missing the enzyme. Can we replace the enzyme? Can that be the right kind of way forward? And then the idea of having clinical trials down the line. And I think as you guys have all seen and through BDSRA, having family involvement really kind of helps us move forward and kind of accelerate some of these paths. Before I finished, I wanted to just chat a little bit about the differences in some of these therapies. And the reason why is because I think we all hear the word, our child may have a rare genetic disease and we're like, well, where's the gene therapy? Where's the next step? What is why, okay, my child has CLN3, but why can't they get enzyme replacement? Questions like that, they come up because we don't know, right, in the beginning, why the mechanisms matter. And so I just wanted to share a little bit about the 3 different types of therapies that are out there for all Battens. Granted, some have enzyme replacement is only for CLN2, but just talking a little bit about that so we understand the pros and cons of each as well. And so enzyme replacement therapy is when we provide and we're able to provide a missing enzyme. And that's what we're able to do in CLN2. It has biweekly intraventricular infusions. Its goal is to slow down the decline. It's lifelong. It's invasive treatment. And at this point in time does not treat vision. There are some ability to do ocular injections as well. And so there's some new data coming out about that, which I think we can keep our ears open for. So that's enzyme replacement therapy. The other one that Dr. Shiloh will talk a little bit more about are kind of ASOs. And so ASOs we end up making synthetic oligos that can modify RNA, and it has to be very specific for the type of genetic mutation that you have. So specifically in the world of CLN3, there's different mutations in CLN3 that can cause a disease process, but there's a most common mutation that we see that we can say, hey, is that something that we can build a personalized treatment for? And then same in CLN7. So this also is not just, a medication you can take by mouth. This is an intrathecal injection that has to have repeated dosing as well. And so, but I think keeping our eyes open because we have the ability to do these things now than we did before. And then the last type of gene therapy that we often hear about, and I think the type that I think most often comes to people's mind is a one shot and done when we think about gene therapy. And that's kind of sometimes where AVV gene therapy, vector gene therapy kind of comes in, and the idea about delivering the functional gene copy to help with long-term enzyme production, long-term good protein production, and the idea of this being a potential one-time treatment. Still, some of these things are in trials, and we're going to spend a lot more time talking about this today. But I thought it would be important to at least go through the different types so we can kind of understand what's on the horizon and what that may mean for our families and for our children. And so I think we talked a little bit about some of the new therapies that are coming. I think something that I wanted to mention on this slide that's really important that I know people are working on is the idea of newborn screening for some of these Batten's diseases, because even with Brineura, like the fact that if you treat so early until we can get a gene therapy, like we can continue to save development in that sense. And so finding out the disease earlier can be beneficial. And then I think that from understanding the science, there is hope. There is an FDA-approved treatment for CLN2, which is Brineura. There's multiple clinical trials for gene therapy and for ASOs that we're going to hear more about now. And there are different kind of new agents. I think this progress is real. I think going back even 10 years ago when some of your families may have been diagnosed or longer, we didn't have these options that are there today. And I think it just shows us how far we've come. And I think a huge part in that is families coming together, advocacy, researchers, everybody kind of coming to the table in events like such as this. And I think that's really important. So those are the things that I wanted to share with you guys today. Thank you guys.
Me? I think I'm in the wrong. Right. Well, first, again, thank you, everyone. And I want to specifically mention, since the Lermans walked a little later, I want to mention their huge part in having this day. So we met about a year ago, I think, in Chicago, and spoke about, we need to bring Duke and UNC together. We need to bring this community together and kind of see how we can all work together to make, not only in this region, but really help families and help moving things forward. So thank you. And I'll go really quickly through 2 topics. Oh, so this is just me. I'm pediatric neurologist, epileptologist. My career has been around genetic disorders, and kind of through that, and actually I will say anything that I ever accomplished or achieved in my career was something that a parent told me. Well, the whole big UNC cannot run a study for CBD. I was like, yeah, well, makes sense. So I see families as and parents that advocate for their kids, kind of my instructions of what's the next thing that I need to do for my patients. So I'll try to go really quickly through 2 topics, and so it will be mostly headlines because we kind of have a lot to cover, and so I'll first talk about the UNC as part of the Batten's Disease Centers of Excellence in collaboration with the BDSRA, and kind of update of some great things that are happening in among that group, which I think will be important. And then I'll talk a little bit about the N of 1 pathway and how we take it to N of many, which is always been the goal. So the Center of Excellence by the BDSRA was actually started to come together in fall of 2023, when the BDSRA decided to kind of reestablish Center of Excellence. Spent about a year in kind of developing what would be a Center of Excellence, what the goal, and then created a Center of Excellence network. And it's this collaboration. We meet twice a month for research, for clinical initiatives. This is kind of what is the requirement to be a center of excellence. And it's these patient-centered care centers, which at UNC we're one of 9 that have these kind of collaboration and kind of reading through. So I'll start with neurology because this is where I am, but genetics, ophthalmology, sorry, this is so small for me to see. Neurosurgery, for example, for the CLN2, palliative care, rehab, genetic counselor, social worker, nurse coordinator. We have triage line and then clinic coordinator, all coming together to provide kind of a comprehensive care. So this is on the clinical side, what a center offers, kind of. And we have, we currently have twice a year multidisciplinary clinic. We try to have just these 2 days so that all families that are seen for Batten disease can be seen, all providers at the same time. Our hope was that it will also be a chance to meet other families, but it becomes really difficult in clinic. So this is something that I feel less successful because everyone are in their own room. But from the healthcare side of it, every one of these multidisciplinary clinic, I realize how much benefit there is in us discussing things. So May, who is one of our providers in the clinic, would come and give her impression of what do we need to do as far as physical therapy, what are some of the questions that came up. There's tremor. Why is there tremor? And we're all trying to put our heads together. Rehab doctor that comes, Dr. Yip, and sees, and kind of all of us talking through together and figuring out, it's extremely beneficial. Every clinic, I'm again surprised by how helpful it is to have everyone thinking through a problem together. This day is part of the funding actually that the BDSRA gave us for, so when they awarded us to be a Center of Excellence affiliate, there was also a grant that was offered if centers want to apply for support for the center. And my budget was mainly to do a family day to support families. So this day is actually paid by this grant from the BDSRA and also from BioMarine, which were extraordinarily generous to also support this day tremendously. So this is another, and then just kind of update. So one update actually from Wednesday or Thursday this week, we submitted the BDSRA and Center of Excellence submitted to get funding from the Rare Disease Clinical Networks, and it's an NIH funded grants to create infrastructure for networks for rare disease to collaborate around research. And the submission was led by Erica Augustine, and it was kind of, to be honest, different people that are experienced in the field were like, yeah, you know that it's not going to go through. It's just the first time. You guys just got together to create these centers. It's fairly new. And then, you know, with the current NIH environment and anxieties, but this week we got a notice that it was approved. So it's, yeah, very exciting. And it's meant to create infrastructure for clinical trials. So how do we get ready so that when different clinical trials come around, the whole kind of our community is ready to start to create the protocols, to recruit, and to be ready to go. So that's one of the main, and then there are other kind of biomarkers and other elements that put into that. So that's, then the other things that among the center, one of them I put here, just kind of this report from the literature of the first person with CLN2 that got intravitreal injections. So I think definitely the CLN2 families around know that this was been in a trial for a while in nationwide, but the support that we got and other centers got by communicating with other centers that already started the treatment. So it's off-label. There's no kind of written protocol, so you have to figure out how our UNC system, for example, how will the pharmacy, what will be the pharmacy instruction to dilute the drug to, and there's no written FDA label to do that. So having the support of different centers that are already gone through this, how do you run it through the huge logistics that is involved in sedation and infusion? So this was extremely helpful to have that team. And UNC, we started about now almost 6 months ago. I say we, it's all Dr. Silverstein. So but soon after, Rush in Chicago started, and other centers are looking into. So that's kind of another benefit of having people around the table, sharing the experience and how to do this. And the other thing was, I believe many here are aware that in British Columbia, Canada, insurance decided not to cover anymore Brineura treatment to Charlie, a young girl, based on assessment scales that I guess the way the British Columbia National Insurance coverage for Brineura, when they read through, they decided that she doesn't qualify anymore. And there was a lot of effort. So I don't want to say that this is definitely the one thing that helped, but in the meeting that we had a few months ago in Lincoln, Nebraska, the whole Center of Excellence discussion, all agenda was completely pushed aside, and the whole time was spent to how do we draft statement from the Center of Excellence by the BDSRA that explain that the criteria to discontinue in British Columbia were not what we recommend, and it ended up to be overturned. And I think that there was a way to kind of having, okay, experts in this field got together and all instructed, probably you need to look again at criteria to discontinue. So she was able to go back on Brineura infusions. So now I'll shift to, and I'll try to do it quickly, into N of 1 and the development of ASO treatment in Batten disease, and how we go from N of 2 to many. The Project Butterfly is a project of N of 2 that Amelia and Mackenzie were treated with antisense oligonucleotide. And the next project that is now kind of our next goal is Project Leaf Clover, which I'll explain how it will apply to many. So Zabronkison, took me a year to learn to say this name, but eventually I did, was named by Karen in honor of the zebrine monkey that Amelia and Mackenzie kind of had accompany them through the years. And they're here. Is this their fifth birthday? Third birthday? Maybe third. Yeah, looks like, yeah. And this is this was a drug that I kept this slide just to show that this is the effort to create an ASO is tremendous, both in teams, but also in cost. So this is just to say that the ForeBatten Foundation that was the Karen and David's founded it, and the funding for this project comes, and also the main team within is the ForeBatten Foundation within this project. Michelle Hastings in University of Michigan is the scientist that developed the ASO, that done all of the research, and a lot of which was supported by by the ForeBatten Foundation as well for years before. And Vanguard is the project manager, which did the drug development and then bringing it to FDA approval. And UNC was the clinical home for this study, still is the clinical home for this study. This is just quickly, ASO are RNA-based therapeutics, so they're not replacing the gene, they're just changing how the RNA is transcribed by changing the way the RNA is read. So it's addressing, after the RNA is already transcribed, it changes the way it translates into a protein. CLN3, and CLN3 has multiple different changes in the gene that can cause CLN3. Similar to other genetic disease, there can be different changes in the gene that can cause the disease. Specifically to Amelia and Mackenzie, they have two different mutations. One of them is the common mutation, which more than 80% of children with CLN3 carry the common mutation. The common mutation kind of, as far as the population background, is a mutation that comes probably from Sweden. So people of Northern European, Scandinavian, Nordic heritage are very, very likely that if their child has CLN3, they have the common mutation. It's not a must, but it's very, very likely that their mutation is the common mutation. Other ethnic groups, it may be much more variable. Amelia and Mackenzie have two different mutations. One of them is the common mutation. The other is an ultra rare mutation. And exactly that mutation, we're not aware of other patients that carry that specific mutation, the rare mutation. So what the ASO is skipping so there are different types of ASO, but exon skipping is one that would skip the area of the gene change and restore protein function by creating slightly shorter protein, but hopefully with a lot or similar function to the full protein. So in this kind of example, there's the mutation would be in exon 2. So if we try to make protein that goes through exon 2, it will basically cause the whole protein not to be produced. But if we can skip it and create protein that is based on exon 1, then 3, then the rest of them, we can rescue the protein to be still effective. So this is kind of the big picture. And this is also why the ASO has to be specific to a mutation. So it has to be, it doesn't necessarily have, sometimes it has to be specific to the exact mutation. But if, for example, two different patients have exon 2 mutation, and by skipping exon 2, we can save protein function, then maybe the same ASO can work for both patients. But if the mutation is in exon 3, that ASO will not help because it works on that specific area in the gene. ASO drugs are for neurological disorder are administered through spinal tap. Their half-life is fairly long, about 4 to 6 months. So dosing is typically every 3 to 4 months. Nevertheless, it's spinal tap, it's sedation, it's but that's kind of the way to deliver these drugs. So this is again just the long list of the development team. Not everyone is included. I learned a lot about how drugs are developed. Super interesting. I still probably can't myself repeat a lot of what exactly all of these groups are doing in checking for effect on toxic in an animal model, checking bioavailability. So what's the dose that you need to give in order to get, but then getting the medication to a patient in this N of 1 mechanism is the reason that this was possible. So the FDA in 2021, so I'll go back, the first antisense oligonucleotide N of 1, so developed for one patient, was Millicin, which happened to be also Batten disease, right? But CLN7. And this was truly groundbreaking by Timothy Yu and his lab in Harvard, where they basically paved the path for other N of 1 drug development with ASO. So following, I believe that that Mila was dosed in 2016, kind of, or I forget if this was when she was dosed or where the drug was developed. And in 2021, the FDA established a new pathway, which is kind of an abbreviated way, which is cheaper as far as, it's not cheap, but as far as drug development, it's a magnitude cheaper to get to patients when it's only very limited patient population. This pathway allowed the N of 2 the N of 2 project to get from starting drug development. Now, there was a lot of science going into years before, but once decided, okay, we think we have an ASO that can help the ultra rare mutation for Amelia and McKinsey, it took a year to go through all of these drug development to get the drug to dosing. And that was possible because of this N of 1 FDA abbreviated process that was established. So we're now about 15 months after the first dose. There's a lot of information here. I just wanted to update that at 1 year, side effects, there were very few, which we know in ASO. ASOs are safe in general. There is some risk, and there's risk of procedures, but in general, they're safe with usually little side effects. So as far as safety, it's been reassuring that it was safe. As far as benefits, it's early, it's 15 months, but at 1 year, so going into the N of 2, our our goal was to stabilize, to stop decline. This was our goal. And we were hoping that by rescuing protein, we can stop decline. But what we didn't expect and was to see improvement, which we have. So it's not a cure, but we do feel that possibly beyond even stabilizing, which we're hoping that will sustain, we do see improvement. And I can go through some of the things, but I just put here on the horse on the left, Mackenzie can have a lot of dystonia. So she would wake up one morning and she's kind of off to the side. And after starting treatment and getting gradually to a higher dose, she had much less of these days and improved in dystonia. All medications that we tried, many of them did not help. And then she started having much more good days. Amelia stopped eating about 2 years before start of the Zabronchison, and stopped drinking. And the kind of on the right, this is about 3 months after starting the Zabronchison, she took a straw and started taking some sips of water. And here, the other photo, she's eating. I'm not sure what she's eating. So what's next? So next is Project 4-Leaf Clover. So, and which is the common mutation, which has always been the goal. And the only reason that the N of 2 and the Project Butterfly came together is because going for the common mutation at that point in time was not going to happen. Since then, which is now only 2 years ago, the kind of this field of N of 1 pathway by the FDA was pushed boundaries to where other disorders that are probably as rare were approved to go through that pathway, where initially it was not accepted as rare enough. Now kind of the boundaries were pushed to where we believe that the common mutation can also go through this abbreviated and cheaper, still very expensive process. So we come to this development for the common mutation this is about 1 kilobase deletion or deletion of exon 7, 8. With knowing kind of proof of concept that the drug that was developed for a different mutation in CLN3 was safe and potentially beneficial. And then we also have the multiple different groups that gained a lot of experience developing the N of 2 to hopefully take it again to an N of 2, but knowing that new ASO would have potential to treat so many other patients. In a similar way, and just kind of to be minded that there are patients that don't have the common mutation. There are in a similar mechanism. So if we have the common mutation, if we have the skipping of exon 9, I believe, which is the Zabronchison, then in a similar mechanism, there can be developed drugs for other areas of the gene and kind of follow this same mechanism. So the ultimate goal is to have the possibility of ASO no matter where your mutation is. Right. So I'm gonna pass to Dr. Ohnsman.
Sure. I'm a PC person, not a Mac person, so I'm really grateful that Dr. Shiloh pulled up my presentation. It's so nice to be here with you today. I'm here representing Tern, as I said, and Tern is a new company. We just celebrated our first anniversary, actually, but we're not new to CLN2. So my partner, Alex Bailey, and I led these programs at Regenx Bio. And when Regenx determined that they wanted to go a different direction strategically, we already had some data that showed us that these were promising programs. And having gotten to know the families in developing the programs, we felt really strongly that we could not let these products expire in a freezer. So we did a really crazy thing and we founded a company, and we're here to talk about it, and things are going really well. But the thing that we keep in mind more than anything is you and your children and your needs. And so we're working with a lot of urgency, to the point where we often work through the night to keep things moving along quickly. And that's because the patients are at the core of everything that we do. So Dr. Patel already explained to you the background of lysosomal storage diseases, and I really don't want to belabor that point, but this is just here to remind you that the waste material is building up in the lysosomes in CLN2 because TPP1 is missing. And as she said, there are many different types, but I put this here really just to highlight that it's not a simple thing to take a cookie cutter approach and to say, okay, so you're developing gene therapies that produce TPP1. Can we just use a different gene, but otherwise the same platform? And can we address all of the other NCLs? It's not that simple. TPP1 has some advantages to it. That's why Brineura has been so successful in slowing the disease for these kids, that some of the other proteins in the other NCLs don't share. So there are different categories, and I just really wanted to call that to your attention, that we would love to be a platform company and just crank out a lot of gene therapies for every type of NCL, but it's not that simple. So as you know, I just mentioned Brineura was approved in 2017, and you know better than anybody else the pros and cons of using Brineura. But one of the things that Brineura does not help with is the vision loss in CLN2. And that's just simply, we believe that it doesn't reach the eyes, and that's why. I'm not really going to talk about the intravitreal use of Brineura because that's not what our company does. But we are seeing results from studies and from off-label use that it is slowing down the progression of the retinal disease. And that's great proof of concept for us and what we're doing with gene therapy. And so what we heard from families all the way in the beginning when Regenx decided that they wanted to develop a brain gene therapy for CLN2 was, that's great, but we have Brineura, but our children are going blind. And that's our biggest unmet need right now. And that's why we focused on the vision loss first. And as you know, all of the children with classic CLN2 will lose their vision by the time they're 7 to 10 years old. So our gene therapy is the same, whether it's for the eye or the brain. This is a little complex, but it really is kind of simple if you follow along with me. So we take a virus and we inactivate it by essentially taking out all of the stuff that makes it work. And then we replace certain things that take advantage of the virus's tendency to go towards nerve cells, including retinal cells, and some other things that kind of activate it when it gets where we want it to be. But then this vector is essentially just the delivery vehicle for the gene that we want to give. So in CLN2, the TPP1 or CLN2 gene is the gene that doesn't work correctly, and that's why the children don't make TPP1. And so basically this is like a little FedEx truck that goes into the brain or into the retina and carries that gene. And one of the neat things about when the virus or the vector is taken up into the cell and it travels to the nucleus of the cell, this is not gene editing. So it doesn't do anything to your child's DNA. The DNA is intact. This doesn't touch it. It sort of sits over and minds its own business in another part of the nucleus and just tells the cell how to make TPP1. And in a nutshell, that's how it works. Now, I mentioned that there are differences between TPP1 and some of the other proteins or substances that are missing in the other NCLs. One of the big advantages is that unlike most gene therapies where only the cells that receive the treatment that actually take up that vector or that virus are treated, TPP1 is also secreted. And so the cell will be treated and it will also make TPP1 that it pumps out into the surrounding extracellular area, and other cells can take it up. And this works whether we're talking about the brain or we're talking about the retina. So in the retina, we actually don't treat the center of the retina. So some of the other ocular gene therapies like Luxturna, which is the first one that was on the market that I helped to work on, that is given in the macula because that's the area that you're trying to preserve. But we're lucky that we can give it outside of the macula and still treat the macula and the rest of the retina as well. So we have this dual mechanism of action. The third advantage, it's not really a treatment, but it's an advantage when you're developing a treatment, is that because it's secreted like that, we can measure how much is being made. So we can take a sample from the front of the eye and measure how much TPP1 is being made in the eye. We can take a sample of the CSF. This is drawn from the children's port every 2 weeks anyway to make sure that they don't have an infection. And we can measure how much TPP1 is in the CSF and is being made. So I think I kind of belabored the point that we have these two products. One is ocular, that's our 381 program, because that was where we started based on what the families told us. This is our furthest along, and we're in phase 1/2. There are some regulatory shortcuts that can be taken in rare diseases, so I can't make any promises, but we have some very clear thoughts about the path that we think we should take, and we have some upcoming conversations with FDA to align our thoughts with theirs, and hopefully they match. 181 is a bit further behind, but we'll talk about where we've been with that too. But first, let me explain a little bit about vision loss in CLN2 so that you understand what we're measuring and what we're trying to accomplish. So vision loss in CLN2 in particular is very fast. In some of the other NCLs, all of the NCLs have vision loss at some point in the disease. Sometimes it comes before the neuro problems. Sometimes it comes afterwards. Sometimes it takes a long time to lose the vision. In CLN2, it's not a long time. It's very fast. But the eyes are very symmetrical in their vision loss, in their retinal degeneration. And that's helpful to us because then what we've done in our trial is we treat one eye and use the other eye as the comparison, and it's the perfect control. We've learned that the photoreceptors, so if you think back to biology from when you were in 7th or 8th grade, like Dr. Patel said, the rods and cones of the retina. So those are the cells, they're specialized kinds of nerve cells, and they collect the light and they change that light into an electrical signal that gets sent to the brain by the optic nerve. Those are the cells that are damaged in the retina in CLN2. And so here, I'm a pediatric ophthalmologist by background. So here, when I would look into a child's eye to see their retina, this is what I would see in color. So this is the optic nerve here with blood vessels coming out to supply blood to the entire retina. And this area that's a little bit darker, that's the macula. So that's the center of the retina where you get your central vision, your sharpest vision for reading and other kinds of detailed work. But the whole retina is important. You know, the peripheral vision is also important. So if you think of this is just a red-free photo of the same thing. We don't see this in real life, but when we take images, sometimes we drop out the red to be able to see some details. If you think about this as sort of the top of a cake, and then you were to slice the cake and look at the layers of the cake, that's what you're looking at here. So this is an image called an OCT, and we can see, so even though the retina is about the thickness of a piece of plastic wrap, and it's transparent like that, it's actually made of a lot of different layers. And the layers towards the bottom here, that's where the photoreceptors are. And we're particularly interested in this second bright white line, the top bright white line. That's one of the layers of the photoreceptors that's called the EZ, the ellipsoid zone. And we'll talk about that in a little bit, but I wanted to show you what it looked like so that you know what we're looking at. The other thing that we look at is the thickness. So if you look at, this is an advanced case of CLN2 retinal degeneration. You can see there's a classic way of describing this called a bullseye. And you can see that that looks like a bullseye, especially when you drop the red out. But you can also see that here where you have all of these layers that are very sharply delineated and easy to see, that they degenerate and it's really not hard to tell, or it is hard to tell those layers apart at that point. You'll also notice that this normal retina is thicker than this CLN2 retina. And one of the things that we measure is in this central part, see where this dip is, that's the fovea, that's where your very sharpest central vision is. We're interested especially in this area for obvious reasons, that's where your sharpest vision is. And so we measure the central thickness of the entire retina, so that would be right here, and also the thickness of the photoreceptor layer in that central area. And you can imagine if you're taking that measurement here versus here, that this is going to be a smaller measurement. And so I wanted to give that to you by way of background so that when I show you some of our data, you understand what I'm talking about. There's another pattern that is worth understanding, and that's the pattern of easy loss, like if you're looking at that surface, if you're looking at it like a map. And so early, we start to see just little nicks right around the fovea that are involved, and those quickly merge into a ring. And then that easy loss spreads into the fovea in the center and outward as well, and keeps extending outward. And we measure within this grid, so that's why it's a neat circle here, but you know, biology doesn't respect circular boundaries like that. So the same thing is happening elsewhere, but the numbers that you'll see refer to being within this grid. So the trial was started under REGENXBIO, and 6 patients were treated. So 3 patients at dose level 1, 3 patients at dose level 2. We have since expanded, and we haven't publicly announced how far into the expansion cohort we are, but we're working hard and we're working quickly. So you can, you know, fill in the blanks for yourselves. And so what I'm going to present to you is data that's already public. So it's not really up to date because we have more data since then. I'll just say that all of the trends are following in the same direction. So we haven't had any surprises since then. But what I'm going to show you is 1-year data for these 3 patients plus this patient, and then 9-month data for these 2. But they have passed the 1-year mark, and the trends are all the same. The first thing, when you give a treatment for the first time, the number one thing that you're concerned about is safety. And we're seeing an excellent safety profile. There haven't been any problems with tolerating the gene therapy. And we talk about serious adverse events, or their abbreviated as SAEs. And because these are sick children, they do have SAEs that are related to their CLN2, but there haven't been any that have been related to the gene therapy, either the product itself or the surgery that it takes to deliver the product. So that's been very promising. So here are some TPP1 results, and I'll just explain this to you so you're not trying to fumble your way through it. This area is the first participant, the second, and the third. At baseline, so at day one, this is before the treatment is given. So this is their own baseline amount of TPP1, and you can see it's pretty close to 0 for everybody. There's a tiny bit of measurable here. This dotted line is, we had some samples of just aqueous humor, the fluid from the front of the eye, just from people, healthy people without CLN2. And so we know approximately how much TPP1 is usually floating around in the aqueous humor. And so that's this dotted line. And you can see in orange that by day 30, these two patients started either exceeded or approaching that amount. And by day 90, they had exceeded it and they continued exceeding it. The third participant is a little bit of a special case. So during the surgery, our surgeon, who is very experienced in subretinal gene therapy surgery, was noticing that the product was coming out. So as he was injecting, it was coming out from we call it a retinotomy, from the little hole that the cannula makes in the retina. He couldn't quantify it, but he said it looked like most of it came out. And he tried in several different locations, but every place that he tried it did it. We don't know why. We haven't seen this in any of our other patients, but that's the story with this patient. And I think that it really explains why their levels remained so low, because they got a low dose that stayed underneath the retina. If you kind of blow up those little invisible bars, now you'll notice this is a much different scale. So this is just a tiny amount. And at baseline, you could see in that treated eye, there's a little bit, and we saw that in other patients. But you can see here that it did increase over the time, and that will be pertinent when I show you some of their retinal results. Okay, so just a reminder again about the sort of pattern of progression that you expect to see, but I put it here primarily because in other diseases where the easy is lost, the patients don't have neurological problems, and so they can do other tests that show that the areas where the easy is missing, the vision is also missing. So they can do special kinds of visual fields where they can test the visual field right in that spot in the retina. And they showed that the retina is not functioning in those specific spots, but it is in other spots. So in CLN2, we're using this as the basis of saying that just like all of those other diseases where easy is lost, we expect that someplace where easy is lost in this disease means that vision is lost. So if you can think about the black areas that I'm going to show you as blind spots. So this is the first patient. And again, just to walk you through it, in all of these slides, I'm going to show you the top row is the treated eye and the bottom row is the untreated eye. You don't really have to worry about these numbers, but these numbers are the area of easy loss. So, you know, you add up all of those black areas and you come up with a number. But really, if you just look at, you know, what the maps look like, it's pretty easy to see that in the untreated eye, it's progressing just like we predicted that it would, because that's the natural history of the disease. And in the untreated eye, after day 30, it seems to have stabilized. And if you kind of do the math and make a sort of like a little visual field map, then if this were a parent who is holding her child at arm's length, in the treated eye at 1 year, this is what that blind spot would block in her face. Whereas in the untreated eye, this is what the blind spot size at that distance at 1 year. This is patient 2. This patient, just like Dr. Shiloh was saying, that they were surprised that they got improvement of the disease, we were really shocked to see that this child actually got better in their treated eye, whereas the untreated eye behaved just as we expected. This is the third patient. Now, this child not only had the issue at surgery where the product was coming out as quickly as it was being injected in, but they also didn't have a lot of easy loss. So not large enough to map at this stage. And we were a little bit surprised by that because they had met the inclusion criteria. So it made it a little bit difficult to show here what was happening. Here, we started to get the idea at 1 year that there was a difference between the two eyes based on that tiny little bit of TPP1 that was being produced. And I'll show you a different way of looking at this that will show that, in fact, that retina was receiving some benefit from the treatment, but we're not there yet. So this is the first participant at dose level 2. I think I might have skipped that slide, but their TPP1 levels were crazy high in dose level 2. So where it was in the hundreds at dose level 1, it was in the thousands at dose level 2. But you can see that they really didn't have better results, and so there wasn't a good reason to use dose level 2. So we settled on dose level 1 as the dose that we would continue with. But here again, you can see a child who improved in this eye and continued to get worse in the other. This is participant 5. You can see that their disease is much more progressed. These are not larger because I got sloppy. They're larger because I needed to show you more of the map to show you how much was missing. And this only goes up to day 270. There is an NCL meeting coming up next month in Australia, and I'll be presenting updated results, but I'll just give you a sneak preview that at day 360, like I said before, we're continuing to see the same trend where this eye was stabilized. And the same thing, now this child was sick for a long time, around day 180, and so they missed that. But at 9 months, you can see the huge difference between the two eyes. And again, at 1 year, we saw the same thing. This is a different way of looking at it. So those were all easy loss. This is photoreceptor layer thickness. Remember I said right in that central area to see the thickness of the photoreceptors. And so in these, this is for all 6 participants. In the top line, the orange line, that shows the treated eye, and the blue is the untreated eye. And so the thickness, you don't want to lose thickness. That's what happens in the natural history of the disease. And you can see that all of the blue lines are going down. This one, maybe not so much in participant 3, but definitely still going down. But you can see that the treated eyes are either staying the same or getting better. And so these two, at the time that this presentation was given, we didn't have day 360, so we hadn't calculated the treatment differences. But this eye, participant 2, I believe is a 99% treatment difference at day 360. And this one is in the 60-some%. So in short, we're really excited about this. So a question that we're anticipating that the FDA and other regulators will give us is, that's great that you showed all of that with the anatomy, but how do we know that it makes a difference in the vision? And that's really tricky in this population because, as you know, in CLN2, the neuro problems come first. And so we had devised a way of testing visual acuity. And in our pilot testing, it worked very well, but it didn't work so well in the trial. And I don't mean to say that the vision got worse. It just wasn't a reliable measurement. So this disease is very symmetrical. In our pilot study, we were able to show that visual acuity was pretty symmetrical in the two eyes, but our results in the trial are just all over the map, even at baseline, and that's how we knew not to trust it. So we're looking at other ways. So one of the ways is there's a visual reception subscale of the Mullen test. I won't go into detail of everything that it is, but for the ophthalmologists in the room, these first 7 items match up pretty closely with what we would call fix and follow vision. And so we were able to use this as a kind of a rudimentary way of looking at visual function and functional vision. The other sad thing about this is when the trial was paused, they stopped collecting this for a long time. And so we have very little data. But the data that we do have is trending towards showing that we are preserving visual function. So that's very promising. And it lined up with what the parents were reporting of what their children were still able to do that they certainly wouldn't have been able to do anymore by natural history. So recognizing their mom from far away, indicating their wants and needs with their line of sight once they were nonverbal, continuing to enjoy their iPads, which you all know how much your kids love their iPads, and things like that. So, again, good safety, preserving and sometimes improving those photoreceptors, early signs that functional vision is following along with what we're seeing in the anatomy. And we're working hard to get this across the finish line. Just pivoting a little bit to 181. Now, this is further behind. There is one child who received this in Brazil, coming up on 3 years ago now. And so I'm going to show you the last presentation, and that went just about up to 2 years for the data. It was a 5-year-old who received the gene therapy. Safety was great. Again, no adverse events that were related to 181. But this is the TPP1 level, so at baseline. Now, this child was receiving Brineura, and you can't really tell the difference when you're measuring TPP1 if you're measuring Brineura or if you're measuring TPP1 that was produced from the gene therapy, so you have to time it accordingly. And we know that after a certain number of days, the amount of measurable Brineura in the CSF is so low that it would measure as 0. And so we were careful to measure during those times. And so what that means is that all of these TPP1 measurements are from 181. They're not from Brineura. And so you can see this was the day of treatment. The measurement was a little bit high because it was, I believe, 9 days after Brineura, if I'm not mistaken. But then these are all long enough after Brineura infusions that this TPP1 is definitely from 181. And, unfortunately in this graph, I can't show you the rest of what happened here, but the parents wanted to discontinue Brineura very early on. And the investigator asked them to stay on for a while because this was so new, it was so unknown of what was going to happen. They did finally discontinue Brineura at 16 months after treatment, and the TPP1 did stay stable. I just don't have that, officially publicly to show you, but the TPP1 did stay stable. This was the seizures. Now, this child had a lot of seizures. So this is before the 181 was administered. In this month, there were so many seizures that the parents just couldn't keep track of them anymore. And so we were really pleased to see that after our 181 administration, that the number of seizures dropped off and stayed low, even after Brineura was discontinued. The child here was on 4 different seizure meds, and 2 of them were discontinued. So they still were on 2 other seizure meds here, but this was a huge quality of life thing for this family and this child. The same Mullen scale, it measures other things too, and so it can measure gross and fine motor and receptive and expressive language. And you can see gross motor did drop off, but fine motor improved slightly and then stayed the same over the 2 years. And receptive and expressive language also stayed approximately stable. So, this is not a cure, like Dr. Shiloh was saying, but it definitely is different from what you would expect from the natural history of the disease. Also, just some clinical observations. At more than 7.5 years old, he was still able to maintain bowel and bladder sphincter control. He was still eating solid food. He was able to stand up with assistance, and he sought out communication. So the parents were really thankful for this treatment. So, similar summary, good safety, good TPP1 expression, great seizure frequency reduction. And so I'm here to offer you hope. We're working really hard for you. Literally, the whole reason that our company exists is because of you and for you, and we'll keep working hard and with urgency on your behalf. Thank you.